consultant in clinical genetics, Institute of Cancer and Genetics, Cardiff University School of Medicine. Welcome, Dhavendra. Thank you very much for joining me.
Well, thank you. It's great to be here in Prague, my first visit, and it's a real honor that you invited me. This is a very interesting conference, and also today happens to be International Clinical Trials Day. I forgot completely, that many years ago, 1747, this naval surgeon discovered vitamin C for scurvy. And as a medical student, I remember, reading about conditions. So that's perfect for the purpose and theme of this conference.
Wonderful. What is the definition of personalized medicine and evidence-based medicine, and what do they mean for clinical trials?
Well, there are three questions. Let me just take you to personalized medicine. I think that's so. If you look at, if you go to see a doctor asks your history. It is very history. That's your history. Nobody else's history. So that is the beginning of the personalized health care. And then the doctor will okay, so let me do a blood test. Okay, that is your result, nobody else's result. So everything is collected and led by doctor. You go to a specialist, again same process, be much more specialized. So in the end, you have got consultation, you have in your file information about you. Now that is personalized information. The idea is to make diagnosis. The second thing is how best to give you treatment, and then what needs to be followed up after you have been given the treatment. Say you had a throat infection and doctor prescribed you antibiotics and doctor hope that you, in 5 days time it will be all clear. Then you go back again, doctor will say, oh, clear, you can go back to work. That's simple way of looking at personalized medicine. Nothing special about that. But what the doctor is also looking for, what antibiotic to give you? What's the basis of diagnosis? Do you have any changes in your blood counts or anything? So that requires evidence to support the interpretation. Okay? So personalized medicine, then evidence is coming along as you move along. Then again, the outcome of whatever treatment was given. So that is all about that. What has not happened in the evidence collection was not properly validated, was not properly controlled by doctors in the proper research setting. That required what we call randomization. Okay, you want to make sure that in the end you have got enough data, the data is properly calculated and then put in the right context. So that's how people start talking about evidence-based medicine. First of all, they went to a clinical condition, then they wanted treatment. The treatment has to be validated by clinical trials, what we call the double-blind randomized trial. You divide patients randomly. You don't know whether this patient and the third person who is going to distribute the medicine has no idea whether group A is affected, group B is affected, and then it's called double-blind randomized trial. So that mathematically, statistically, you will get a lot of power. So this has been around for many years. But because we didn't have sophistication in the technology, and technology was changing, and technology was very broad-based, it was not very specific that it will be applied only for a small group of patients. So the evidence-based information was poor quality. So the personalized medicine, the personalized healthcare, that has been around, but it was not properly supported. What has happened that when the new genetic conditions were diagnosed and we came to know about precise genetic abnormality and pathology, and then we became much more informative about and technology developed. Then we came along the genome sequencing. When we have the Human Genome Project, completed in 2003, we had a lot more information, technology was improving. So then we thought, okay, let's just go at that level. That is very much personalized because not only we're talking about person, but we're talking about person's genetic makeup. What is that telling us? And how could we use that information in designing the clinical trial? So then in the genomic context, so both personalized medicine and the evidence-based medicine using the genomic profile and designing a clinical trial, all these things are put together now, and that's what we are trying to really hope. And we have identified molecules which led to the new drug discovery. Then naturally the drug discovery requires many phases, but if you go back as a concept, it's nothing new. We always wanted to treat a patient at a very personal level, and that we are trying to achieve now because we have gotten better technology, much more sophisticated technology, and also opportunity for new drug development.
What is the potential impact of evidence-based medicine on public health?
That's another good question. And so, as you know, public health is not personalized. Public health is about a group of people living in a small geographic area. You see, the Prague you can divide Prague into say 10 small areas. And you think that this one area has got a group of people, they have got same lifestyle, they all say farmers, and they live more or less same style. Other group is much more like working in a factory, and they have a same different style. But so these people, if you look at closely, they are exposed to environment in a uniform way, generally speaking. And also they belong to a community which is also similar looking community. So if you have a condition in that community, take for example, somehow they develop blood pressure. Why is that? If you ask GP and doctors in that area, yeah, that group, from that part of Prague, got many high blood pressure patients. Something is odd. So then you look at closely, is it because of the environment? Is it because they have eating style? Are they consuming too much salt and alcohol every day that it causes the high blood pressure? Or is there something more happening? Then if you remove that, okay, you can control environment, okay, no, don't eat salt, take exercise, and don't drink too much, cut down the alcohol, and then you see whether it has made any difference. If it has not made any difference, that means your idea, your philosophy of salt and diet was wrong. So there may be something different. Then it comes to the genomic makeup of that population. So there are two ways of looking at it. Either you go around genome sequencing many people in that community, and we have done that. This is called Genome-Wide Association Studies, called GWAS. You may have heard the name. GWAS is very time consuming, very expensive. Just imagine you have 10,000 people from that community. You are sequencing, looking for genomic signals that may give you a clue to high blood pressure. But nothing is happening because you have found nothing. But suppose there are few families in that area, they got very early onset high blood pressure, children, high blood pressure. You found genetic condition that causes high blood pressure. We found a very specific gene change in those families. Now that could be the clue. That means rather than going sequencing the whole genome of people, you can say this is a genomic marker in that area, and that is found in 6 families with high blood pressure. Could that be present in other people also? That is public health. You follow that?
Mm-hmm.
Now I can give an example, a condition which we are doing, which in my area we have got a program. Condition is called Familial Hypercholesterolemia. Have you heard that?
No.
It's called FH. Means genetically you cannot handle your fat in the liver. Enzyme is missing. There's a gene fault. And it is familial, as the name indicates. So generations and generations within a family will have high cholesterol. They don't have too much fat in their diet. Some are vegetarian. They don't touch meat. Yet their cholesterol is very high because they can't handle at the gene level. So it becomes very high. As a result, they have heart attack. They die because the blood high fat in the blood can get arteries clogged up of the heart, coronary arteries. They have myocardial infarction, heart attack, they die in 40s, in 30s. And some children may die very young. So that led to another point of public health. Could we use this gene marker, gene change, at a wider public health level? Knowing that they have quite uniform lifestyle, they always go to, they have three times a week, they have a good massive pork joint or lamb or whatever, they have rich fatty diet, and yet, some are living, some are dying early. So in order to give them benefit of this new knowledge, what we have decided in the UK, in my part, in Wales, that we are now testing, we are offering these patients who have got high blood pressure or family history of heart disease, heart attack. We test their genetic profile for high cholesterol genes. There are 3 different genes, and every patient, every person, no, they are not patients, they are just healthy people. That's public health. In public health, people are people, they are not patients. So we want to prevent them from being a patient. Did you agree?
Yes.
That's public health. So once we have identified a mutation in the gene, for example, it's called LDR, low density lipoprotein receptor gene, LDRL. The other gene is called PCSK9, and third gene is called ApoB. These are 3 genes, but most common is LDLR. And so suppose we have found a gene change in a patient, in a person, not patient, person. We can give them drugs called statins. You may have heard called drug statin. They can cut down they can cut down the cholesterol level very rapidly over 2-3 months. And then we can also go and check all first-degree relatives or that person in the family. Say, if somebody at the age of 40 years was found, so we can offer tests to his parents and brothers, sisters, and children. These are first-degree relatives. They have got 50% chance, 1 in 2 chance to share that gene change, a gene marker. That is a good example of public health medicine. Again, based on evidence we collected from selected families with familial hypercholesterolemia. Do you know what I mean? So that is answer to your question. Yes, evidence-based medicine is also going to public health medicine. That is a short answer. And sometimes people call it personalized healthcare. That's fine, they can call whatever they want to call, but the concept is that you start from selected families and validate that finding, then go to the community of the public health level, then you pick up some persons and go back to their families and then offer them targeted, personalized, preventive health care. That's essentially we are doing. And there is a lot of things are happening. People are talking about, even for like bronchial asthma, they're talking about skin, they're talking about skin cancer, malignant melanoma. If you 10 people go and on the beach, they bake their skin. 2 develop skin cancer, 8 they don't. Why? Same kind of people, they have exactly the same level of exposure to sun, isn't it? But not everybody develops. So if you have got a gene marker for skin cancer, and you can go back to people, okay, by the way, you're going to Australia or going to south of Spain for 15 days and you'll be lying in the sun, practically naked, whole body is exposed. So if you have got gene marker, you can say, be careful, you've got gene marker, you'll develop cancer. So you should not expose yourself. That is the example of public health medicine.
Okay, great. Thank you so much for that.